Tackling the Mystery of Mast Cell Activation Syndrome, MCAS, in Canada, a hands-on guide for diagnosis and treatment. Imagine suddenly feeling your heart race, breaking out in hives, or struggling to breathe, all without any obvious trigger. This frightening scenario plagues many patients seeking help from allergists, often pointing to a complex condition known as Mast Cell Activation Syndrome, MCAS. But here's where it gets controversial. While some experts advocate for strict diagnostic rules to avoid overdiagnosing, others push for broader criteria that could help more people. In this review, we'll walk through a practical, step-by-step approach to diagnosing and managing MCAS in Canada, drawing from the latest guidelines by the European Competence Network on Mastocytosis, American Initiative on Mast Cell Diseases, ECNMAIM. We'll keep things clear and beginner-friendly, expanding on key concepts with real-world examples to make it easier to grasp. And this is the part most people miss. Understanding MCAS isn't just about symptoms. It's about tailoring care to each person's unique situation, potentially transforming lives affected by unexplained health challenges. Review. Open access, https://www.springernature.com/gp/open-science/about/the-fundamental-of-and-open-research. Published, November 21, 2025. Erica Lee Superscript 1 Superscript 2 Superscript 3 N. Matthew Picard. Allergy, Asthma and Clinical Immunology, https://aacijournal.biomedcentral.com, Volume 21, Article Number 49, 2025. Cite this article. Abstract. A growing number of individuals are turning to allergists with complaints of persistent, puzzling multisystem symptoms, often linked to Mast Cell Activation Syndrome, MCAS. This article presents a straightforward, evidence-based roadmap for diagnosing and treating MCAS, grounded in the consensus criteria from the ECNMAIM Consortium, a respected group of global experts in mast cell disorders, backed by major organizations like the American Academy of Allergy, Asthma and Immunology. The process begins by confirming that the patient's symptoms align with MCAS, where idiopathic anaphylaxis serves as the classic example. Symptoms must be intense, recurring, indicative of mast cell activation, and affect multiple organ systems. Next, rule out secondary triggers like cofactor-dependent food allergies or reactions to nonsteroidal anti-inflammatory drugs, NSAIDs. Then, gather objective proof of mast cell activation, ideally through a spike in serum tryptase levels, measured within 4 hours of an episode, compared to the patient's baseline. As an alternative, check urinary metabolites of mast cell mediators, comparing baseline levels to those taken 3 to 6 hours after an event. Keep in mind that high baseline tryptase or urinary levels alone aren't enough for diagnosis, and normal results don't rule it out. For those with idiopathic anaphylaxis, screening for clonal mast cell disorders, such as examining baseline tryptase, testing for the KITP.D816V mutation via sensitive blood tests, and calculating a mast cell clonality prediction score, is essential. If there's a high chance of clonality, a bone marrow biopsy might be needed. Treatment focuses on equipping patients with epinephrine autoinjectors for acute flare-ups, especially when anaphylaxis is involved. For frequent episodes, start with prophylactic medications like H1 antihistamines, escalating as necessary. Most patients see positive outcomes, but some need a mix of therapies to control symptoms. Ongoing research aims to refine diagnostic and treatment methods. In everyday practice, better access to tools like urinary mediator assays, advanced KIT mutation testing, and tryptase genotyping could greatly enhance patient care in Canada. To give you a quick example, think of a patient who experiences sudden flushing, abdominal pain, and dizziness multiple times a month. Diagnosing and managing MCAS could prevent life-threatening episodes, but it requires careful, individualized steps to avoid missing underlying issues like hidden allergies. Introduction. Mast Cell Activation Syndrome, MCAS, represents a multifaceted disorder marked by acute, intermittent symptoms mirroring mast cell activation, impacting at least 2 different organ systems, 1, 2, 3, 4, 5. While discussions of this syndrome have appeared in medical journals for decades, the term MCAS only gained widespread attention in the 2000s. 1-6. What started as a clear-cut diagnosis soon became entangled with a wide range of nonspecific complaints, lacking strong evidence that it fully explains these broad symptoms. 1. For instance, patients might report headaches, fatigue, brain fog, concentration difficulties, and memory problems alongside recurrent episodes of classic mast cell activation, like anaphylaxis. However, the root causes of these ongoing issues remain unclear, and their response to anti-mediator therapies can vary significantly. 11. This raises a controversial point. Is MCAS truly behind all these symptoms, or are we lumping together different conditions? Experts debate this fiercely, with some suggesting MCAS is overdiagnosed, while others argue it's underrecognized. But here's the key: if you're dealing with frequent, unexplained attacks, understanding MCAS could be the missing piece to regaining control. To address these uncertainties, Akin and colleagues introduced the first diagnostic guidelines in 2010, aiming to prevent overdiagnosis and promote evidence-based care. 1. They also categorized mast cell activation disorders into primary, involving a clonal mast cell issue, secondary, triggered by a known condition, and idiopathic forms. 1. These guidelines have evolved, incorporating new categories like combined or mixed MCAS, primary plus secondary, and hereditary alpha-tryptosemia, H-alpha-T, associated MCAS, occurring alongside H-alpha-T. 3. These are now known as the ECNMAIM Consortium Criteria 2, 3, 5, 7, supported by top scientific bodies such as the American Academy of Allergy, Asthma and Immunology 3, 8. Yet, a different group of specialists has proposed more expansive criteria for MCAS, viewing it as an extraordinarily intricate condition stemming from chronic mast cell overstimulation, potentially affecting up to 17% of the population. 9. Here, patients with any assortment of symptoms not explained by other diagnoses, showing some improvement with anti-mediator treatment, could qualify. 9. Critics, however, argue these broader standards lack specificity and evidence linking such varied symptoms to persistent mast cell activation. 4, 7, 10, 11, 12. For example, while MCAS patients might experience fatigue or headaches, those are often chronic and not tied to acute episodes. This is where the controversy heats up. Are we helping more patients by broadening the definition, or risking unnecessary treatments for unrelated issues? It's a debate worth pondering. Do you think stricter criteria protect against false diagnoses, or do they leave people suffering without answers? Recent studies have explored possible connections between MCAS and other conditions, like postural orthostatic tachycardia syndrome, POTS, hypermobile Ehlers-Danlos syndrome, HEDS, or long COVID, post-acute sequelae of COVID-19. However, these links haven't been confirmed in patients meeting strict ECNMAIM criteria 8, 13, 14, 15, 16, 17, 18. And this is the part most people miss. Alpha-Gal syndrome, though rare in Canada due to the Lone Star Ticks geographic limits, might be mistaken for MCAS and should be considered. 2734. This guide follows the ECNMAIM criteria to offer a tailored strategy for Canadian allergists, focusing on diagnosing and managing MCAS while checking for coexisting clonal mast cell disorders, CMCD, and excluding secondary mast cell activation, MCA, causes. MCAS can occur in children, but our approach, based largely on adult data, draws from limited pediatric studies. Diagnosis. To confirm MCAS, all three ECNMAIM criteria must be satisfied. 3. Typical clinical markers of severe, episodic systemic MCA are evident, usually as anaphylaxis. Systemic means affecting at least 2 organ systems. Mast cell involvement is confirmed via biochemical tests. The top choice is an increase in serum tryptase from the individual's baseline by at least 120% plus 2 nanograms per milliliter. Other mast cell-derived markers, like 24-hour or spot urinary histamine metabolites or prostaglandin D2 metabolites, can be used but are less reliable than tryptase. No set thresholds exist for these urinary markers yet, so they're suggested when tryptase isn't feasible or inconclusive. A possible cutoff is a 200